So our next speaker is Dr. Carlos Abril, marginal anastomotic ulcers after bariatric surgery.
Oh, well, don't worry. I think I know how to connect it, but you never know. Yeah, well, wait a minute. I'm gonna open it, and it will go in a minute. It should go, right? It takes. It is. Should go. Yeah. So good morning, everyone. Again, no, afternoon. It's not morning. So we're going to talk about the marginal and anastomotic ulcers, which is something frequent and challenging because you don't know what to do with them. And we still don't know the reason of why. Yeah, if I ask you now, so what's the reason of the anastomotic ulcers? That's a good point. More. How many patients did you have in your life that, are you taking NSAIDs? You're waiting for them to say, yeah, I'm taking, oh, that's, stop it and you will get cured. No, I'm not taking that. Maybe you're a smoker. No, I don't smoke, so. Well, what about ischemia? Why didn't ischemia? Why did this happen in 6, 9 months, 2 years after bypass? Where's the ischemia coming from? Okay, but it's 6 months after, 1 year, 2 years after. So you don't have a reason because we don't know why. So I would be really happy if today someone can, not today, you can read this paper. This paper is made by John Alberti. And you say biology of anastomotic healing, the unknown overwhelms the known. It's not only for residents, it's for everybody, because I still see that we don't know the biology of our body. So when you cut your hand, when you hit your head, you have an injury, it heals, right? It heals. Wow, why? Did you ever think about it? It's the same when we do a surgery. If we cut things and we connect them, the mechanism that our body uses to heal is the same like a wound in the skin, the same one. So your body doesn't know where the wound is, only heals, right? And when we have a failure in that process is when we can find the reason and we can find the treatment. And for that, look at this definition in that paper. So the body must achieve hemostasis, decontaminate the site of injury, cover the wound and induce cellular differentiation to form all layers of the prior tissue to fully regain integrity, strength, and function. Simple thing, but that's the way everything heals. And we have to keep in mind one thing. Every time you have an injury, every time you do a surgery, every time you touch the hiatus, every time you do a C-section, the scar is only 70% the strength of the primary tissue. Don't expect that the healing is complete as it was at the beginning. And that says a lot. So all the healing process takes 3 steps, which is inflammation the first days, and those ones are the neutrophils, and platelet-derived growth factors, and TGF-beta, so vascular endothelial growth factors. All of them are bringing on the scene cells to heal, and it takes days. After days, it takes weeks, and you say, this we know. No, nobody knows. If you look at that, nobody knows, because I keep seeing my colleagues say, after 6 years of a surgery, the patient comes to you, the sleeve is not working, the patient is vomiting, or after a bypass, 6 weeks after, you say, what's going on? That's proliferation thing. So every tissue, any heal, any injury gets stiffness because many cells get there, and that stiffness means that in your wound that nothing happens. But if you connected the stomach to the bowel or the bowel to the bowel, there's an inflammation, there's a rigid thing, it's not moving properly. So it's a natural thing what happens. And we keep saying, we're going to put steroids, we're going to do this. Leave it, it's the body. If there's nothing in between, if there's nothing wrong, keep it. There's no problem. And then remodeling. You have a patient with an inguinal hernia and comes to you, I have 8 months, I have pain. The healing process takes 10 months to happen. 10 months to happen. So if you have an inguinal hernia patient coming 6 months after the surgery, I feel in this pain now, it's normal. It's completely normal. Even though the skin is healed, everything, there are many things ongoing there. And it's completely normal. So you have to tell your patient, you have an inguinal hernia, you have something, there's something going on there, because that's what it takes. So nobody comes to you, a pregnant woman, saying, oh, I have this pregnancy, can you take it out in 3 months? No, it takes 9. It takes 9. So the healing process, it doesn't take 9, but it depends, it's between 8 and 10 months. And in the remodeling thing, you have the matrix myeloproteinases. There are enzymes there. There are some bacteria that they activate, some of them. There's the MMP9. What happens with that? That one doesn't let the collagen converts to collagen 1. And it's one of the reasons that some bacteria increases the risk of leaks in colorectal cancer, in colorectal surgery, not cancer, sorry. Why? Because there are bacteria. There are bacteria that they promote the transition from the plasminogen to plasmin. And what does it do? So we remove the clot from the system. So the risk of leak is higher. So there are studies saying that if you apply tranexamic acid, that you know that block the movement from plasminogen to plasmin, if you apply that, decreases the risk of leaks. So we always think about healing. What's the reason of a leak? Oh, it's the perfusion, ischemia. That's okay. It's the nutrition. We never study nutrition. That's not true. It's mechanical stress. It's the tension. You've done surgeries. I was colorectal before. I remember patients with a tension in the surgery. You finish. You don't release the left angle of the colon, and the patient has a normal. You release the colon. It's floppy, the colon, and you have a fistula. So those things are things that we learn from others, and we never question that. I can tell you there are studies in animals, in dogs, that you remove bacteria, certain type of bacteria from the colon, you create ischemia, real ischemia in that bowel, and you don't have a leak. So you don't have a leak. Technical problems, of course, technical problems, but the microbiome plays a role in all our lives, in bariatrics, in the obesity, and all diseases plays a role, and you need to learn about that. The mesenteric biology, you know, the cocoas anastomosis that decrease dramatically the leaks. This is Japanese surgery in Crohn's disease. If you avoid the mesentery in the anastomosis, there are less inflammation and the risk of leak is much lower. So mechanical things, and of course about other things that they are very complicated. But regarding the marginal ulcers, we always know about the anatomy. We've done a bypass. So we need to look at the anatomy and the surgical factors. What happens? Does size matter? Well, apparently in this paper from Nimeri and the North Carolina people, they say that size really matters. Every 5 centimeters cubic ones increase in the size of the pouch, you have an increase in the risk of marginal ulcer. Is that true? Don't know. Probably there's an association, but it's not a causation of the thing. Why not one anastomosis gastric bypass has more? The pouch of the gastric bypass is bigger. Mini gastric bypass has a larger pouch than the room. Why? You don't have that high marginal ulcers. For example, another thing, I don't know, in my country we had a lot of incidents of gastric cancer. We did a lot of distal gastrectomies, right? Big pouch, because you have a bigger pouch than the room-wide gastric bypass. We do room-wide. Do we have incidents of ulcers? No. And in my country, back home, they smoke. They smoke, they drink, so they have a lot of things on top. Do we have? It's very rare to have a marginal ulcer. So why is the pouch? Well, I don't think it's the pouch. Absorbable sutures versus non-absorbable. Okay, there's a foreign body, so it's true that it's a double risk of marginal ulcers if you are using a non-absorbable versus an absorbable one. And why, if you're going to do a circular stapler, linear stapler versus Hansen anastomosis? So highest incidence of marginal ulcers, circular stapler. Why? I don't know. Second one, linear stapler. The reason? I don't know. And the third one, hands-on. But we do hands-on, and we have a bunch of patients with marginal ulcers. They are not smokers. They are females. They are not taking NSAIDs, and we don't know why. So, what about H. pylori? How many of you take the H. pylori and treat it? I know. I don't treat it. So if you want, because people, they love, say, when you say the word ACMBS, says that H. pylori doesn't agree that is causing of marginal ulcers, then everybody says it's right. But it's true. H. pylori, for example, when the H. pylori is positive in the antrum, it causes hypersecretion, hyperacidity. But if it's in the foot, if it's in the body, it causes achlorhydria, decrease of the acidity. It's true that increases the circulation of interleukin-1, affects chronic inflammation in that area, but it's not proved in all the patients. Of course, you tell me, I have a patient with a marginal ulcer, I take a biopsy, which, by the way, is the best way to know if you have or not. Biopsy. Don't rely on other tests. But if I have it, I will treat it. Do I have science behind it? Not at all. Nothing. Smoking, definitely. Smoking, what does it? Smoking means nicotine. So many people, I stop smoking, but I have this patch of nicotine patch here. Oh, perfect, that's great. That's great. So you are at risk. Even there are studies saying that even if you stop 4 years before the surgery, you will get issues with the healing. Because we're not talking about marginal ulcers. We're talking about smoking in marginal ulcers because we are doing a room-wide gastric bypass. But that affects colon surgery, that affects hernia surgery, that affects any healing process in the body. Okay, why? Increases sympathetic tone, decreases the BEGF, reduce fibrous activity, and the nitric oxide is completely decreased, which is the best factor to have nitric oxide in the body.
3 minutes left.
And the best factor to have that and to treat hypertension is the sun. Ultraviolet A is the most powerful released nitric oxide in the body. Many times you go to the sun and you get vasodilated, right? The sun has ultraviolet A has a lot of plate. NSAIDs, well, what to say? Prostaglandins. The prostaglandins, what they do? They increase the mucus, they increase the bicarbonate in the environment, they increase the tightness of the cells in the base, and increases the blood flow. So everything is good. What do we do if we do anti-inflammatory drug? We inhibit the COX. We inhibit the prostaglandins. So what we do is to decrease the fences of the, so definitely, and you don't need to take that many. You don't need to take that many. One medication can cause an ulcer in the patient, and it's very correlated to that. Look at that, you look at papers, and this is written by Omar Ghanem and Barham Abu Tayyib, we know them, and we know one of them was Mohammed Al-Haddad, which is a fantastic guy. So they did this systematic review about predictors of marginal ulcers. Diabetes, smoking, H. pylori. H. pylori is not proof at all. Smoking, definitely, and they don't even mention NSAIDs. So it's not clear at all. So you're going to face issues with this. This is a real case. This is a patient that had a sleeve gastrectomy. He was complaining about a lot of reflux. So we did a surgery, did a bypass. The bypass patient developed an ulcer. The one on this side was a month after surgery. We start treating 2 months after surgery. It's even worse. More located, but even worse. What do we do? Treatment. Okay. So still in pain, still with problems, still with ulcers. What do we do? Thoracoscopic vagotomy. Do we have that ulcer there, which is here, close to the staplers, but patient in pain. Patient in pain. What do? We resect the anastomosis. We redo the anastomosis again. Do you have another foreign body? Of course. One thing that I want to tell you, if you're going to redo an anastomosis, I don't recommend you to do that, but don't repeat the same things that you did at the beginning. Change it. Because we don't know what's the reason. So if you did a linear stapler, do Hanson. If you did it Hanson, change the material that you use at the time of doing the surgery. Change something, because repeating the same thing, why do you expect different outcomes? So patients in obesity, when they regain weight, they're going back to the same habits that they were having. Most of them, most of us, don't expect different outcomes. You're going to have the same ones. So what ended up doing? Well, reversion of the surgery, go back to the sleeve. So this patient ended up with a sleeve gastrectomy, with one vagotomy and 2 more surgeries in between. Thanks God the patient didn't develop any fistula, any issue, but I have to tell you that there's no ulcers, right? But the patient is in pain. And the most important thing that I can deliver today to you is this paper from Schulman. When you take PPIs, so what do you think the pharmaceuticals did the PPI? Because they want to sell a lot of drugs. They want to sell them to everyone. So you go, you eat, but I have a pain, I'm gonna take this medication. Those medications are intended for normal people with a full stomach. They give a capsule, or the way they do it, what happens? If you take in a bypass, you take this capsule, that capsule goes to the jejunum in a minute, where there's no acid environment, where it's gonna destroy the capsule probably when it's getting to the ileum, so the absorption of it is minimal. So if you have a patient with a marginal ulcer after mini gastric bypass, after room-wide gastric bypass, please tell them, smash the capsule if it's a tablet, or open the capsule and take it. Otherwise, it will not work. And this paper proves clearly that if you don't do that, it will take almost a year to cure the ulcer. If you open the capsule, if you break the tablet, it will take 3 months to heal. And you have to repeat it 1,000 times to the patients. First to yourself, and then to the patients, because they will not do it, because for them it's a burden to open the capsule twice a day, take it. I ended up taking, that's why it's not healing, because you're not getting the rest. This is not magic. We think that we take the pill, oh, now it's acting. No, it's not. There's a delivery system in all drugs. So remember, those drugs are intended for normal people. Rule-wide, you have to give this medication in a different way. This paper proves that. I was doing these things before knowing that paper. I'm glad, because I don't have science behind that, but now we do have. Finishing, I'm sure that I took more time. Thank you very much. This is our beautiful hospital where we work, or we pretend to work, and where you are invited anytime to visit us.
Great.
Thank you very much.
Thank you very much. So